Hello, welcome back. So, we will look at the anesthesia considerations for patients who have acute kidney injury. So, things that we need to consider when we're taking care of this patient as anesthesia professionals. So, surgery and anesthesia itself, we know it's going to decrease the renal blood flow and the GFR. So these catecholamines that are being released during the surgical procedure and the stress being released during the surgical procedure increases renal vascular resistance. So therefore, it will definitely reduce your RBs, your renal blood flow, which further decreases your glomerular filtration rate. So there, there are reasons why these are happening. So during anesthesia, we know there are periods wherein when we start inducing the patients and we're maintaining using gases or volatile agents, there is a high tendency that our patients will be hypotensive. And then you combine that with other specific procedure specific interventions such as cross lumping, or if the patient is having a bleeding or the patient is having sepsis already because during the surgical process after, let's say, incision of the bladder, I'm sorry, of the bowel, there was some stuff that are not supposed to be in the belly, so therefore the patient develops sepsis. So all these combined that are going to be surgical specific plus all the anesthesia that we're giving can cumulatively decrease renal blood flow. So you know already with our pharmacology lectures or classes this semester that majority of the anesthetic agents have negative effects on your blood pressure and your cardiac output, and this is not really surprising at all. So we know those effects. They tend to lower everything, and it's not good, especially if we're having issues with acute kidney injury. Also, to take into consideration, most of us like to prepare our vasopressors ahead of time, and I encourage you guys to do that. However, some of our vasopressors, well, majority of our vasopressors can really affect the GFR of the patient because of the renal blood flow. Now, in terms of the use of neuroaxial blockade, it depends on the level. That's why I put here it's variable. It depends on the level of the neuroaxial blockade. If it did not reach the cardio accelerator nerves, which are T1 to T4, then the tendency for that blood pressure to go down is really minimal. Now, I tell you, most of the time when you do your axial blockade, especially your spinal anesthesia, most of the time, whether you like it or not, perhaps because of the veracity of the local anesthetic that you use or the position of the patient, most of the time it's going to reach the cardio accelerator nerves, which are T1 to T4. Once it reaches that, it's going to block those nerves. When it blocks those cardio accelerator nerves, then you're going to have problems with your blood pressure and your heart rate, therefore causing your cardiac output to go down. Now, with that, that's going to affect renal blood flow as well. Okay? So these are the two slides that talks about the anesthesia considerations for patients with acute kidney injury. Now we're going to go to patients who have chronic renal failure. So chronic renal failure is a progressive, irreversible deterioration of the renal function. Usually is caused by diabetes followed by hypertension. Now, it is suggested in most patients a decrease in GFR of less than 25 eventually progresses to end-stage renal failure, which requires renal dialysis or renal transplantation. So what are the clinical manifestations or presentations of patients with chronic renal disease? First and foremost, they're very anemic. The anemia is secondary to the fact that the kidney is the primary source of erythropoietin. Now, there is no issue with the platelet count itself. Actually, the patient doesn't have really thrombocytopenia, but the patient has a tendency that the bleeding time is going to be longer due to platelet dysfunction. So not secondary to thrombocytopenia, but the dysfunction of the platelet. Now, patients who are chronically having renal failure or end-stage renal failure tend to have hyperkalemia or hypermagnesemia. Again, this will definitely change immediately after hemodialysis, and we know that. Other things that we need to do to make sure that our chronic renal patients are being taken care of in the OR is we have to look at the comorbidities. As I mentioned earlier, diabetes and hypertension may be present for patients with chronic renal failure, but other conditions may be present as well. What if the patient has congestive heart failure? What if the patient has aortic stenosis? Those are the things that we need to take into consideration when we're putting a patient to sleep, especially if they have chronic renal failure. Another consideration, we make sure that the creatinine level are monitored and we know the trends of the creatinine level. This can be done by looking at previous charts or you looking at your epic. Now, the patient's volume status may be estimated by using their weights before and after hemodialysis. Remember, after hemodialysis, the patient will definitely gonna have hypotension and definitely gonna have tachycardia because they the number of fluids may be too high in terms of the removal during the hemodialysis. One way to do this is to look at the hemodialysis chart. Usually they have like flow sheet for their hemodialysis and determine how many liters that they remove during hemodialysis. That gives you an idea on how you're gonna tackle your fluids in the OR. Now remember, with these patients who are chronic renal failure, you don't want to give too much fluid as well, right? Because you don't want them to be fluid overloaded. So as one of the things that you can do is instead of hanging a 1 liter bag of normal saline, how about just hanging a 250 bag of normal saline and titrate the amount of fluids you're going to give using a micro drip instead of a macro drip. That way you can control the amount of fluids given to the patient. This is the patient wherein you can't give too much and you can't give too little as well, because if you give too little, remember they're already hypertensive. So you want to maximize everything that you do in the operating room. So you also want to look at the glucose level because you want to manage that. Remember, diabetes is the leading cause of end-stage renal failure in the US. You want to control the blood pressure. If they're taking antihypertensive medications, you need to administer them. However, I would like to advise everybody that if they're taking ARBs or ACE inhibitors, withhold it on the day of surgery to avoid intraoperative hypotension. You don't want to be in that situation where you're trying to solve hypotension. Remember, patients may have other comorbidities, especially with chronic renal failure. What if they have issues with aortic stenosis? What if they have comorbidities such as coronary artery disease? When you give ACE inhibitors and ARBs and you worsen the hypertension, what happens to the myocardium? There's not going to be enough coronary perfusion. You're going to have an MI, and guess who are they going to blame? They're going to blame us for that. So watch your ACE and ARBs and withhold it the day of surgery. Now, sometimes you can't get hold of this, right? They've done it, the patient took it before they came to the OR, and the reason why they took it because somebody told them to take it, right? Or somebody did not tell them not to take it. So either way, right? So if that's the case, then you're really gonna prepare ahead. You're gonna prepare all your vasopressors that you really need, because you can't give too much fluids, right? So you're gonna use some vasopressors to augment your blood pressure in that setting. So we look at potassium level as well. So I'm putting a number here depending on the hospital you're working with. 5.5 may be normal for them, but it's still high. So anything that's higher than 5.5, you don't proceed with the surgery, especially if it's elective procedure. Now, patients who are diabetic have gastric paresis, right? So after induction, try to aspirate using an OGT, or before induction you can give all your H2 blockers that you can use. However, when you give H2 blockers, you try to minimize or lower the dose because it's excreted in the kidneys. They can also proceed with hemodialysis if needed after the surgery, and usually this is decided by the renal doctor when they're gonna go for hemodialysis, but it's acceptable that they can go for hemodialysis after surgery. So really, don't when we do a patient with renal disease, especially chronic renal failure, really be very meticulous and be very vigilant with the amount of fluids that you're going to give this patient. You don't want to extubate the patient and then patient has been coughing the whole time because he or she is congested. So be very careful in the amount of fluids that you're going to give. As I've said before, we try to hang 250 cc of that normal saline and titrate it using a micro drip instead of the macro drip. Okay, I'm gonna stop here. We're gonna proceed with the induction of anesthesia in the next video presentation.